The recording is going to be on two sections of your Module 12. We're just going to be doing Module 12D, which is on osteoporosis, and 12E, thyroid disease, the medications for both of those sections. The first one is your osteoporosis drug management. First group of drugs, the SERMs, should be familiar to because we covered them in the female drug sexual disorder and postmenopausal before. So selective estrogen receptor modulators, or SERMs. And the one to focus on here is raloxifene, or Evista. It is currently the only FDA-approved estrogen agonist antagonist for FDA approved for osteoporosis at this time. You can find information on SERM in your Pearson text on page 804, and also raloxifene is in your drug handbook starting on page 986. There is that black box warning, which we've talked about before, for DVT, pulmonary embolus, and death due to stroke. It's an adverse effect, obviously. That's a very poor outcome. Adverse effect. It can only be used in women because it is an estrogen. It decreases the bone resorption, which leads to an increase in bone density, decreasing the fracture risk. Is contraindicated in anyone that has a history of any thrombolytic event, whether they had a pulmonary embolus, a deep vein thrombosis, a clot anywhere in their body. It is a contraindication. It's contraindicated in pregnancy and any plan for pregnancy, and it's contraindicated in lactation. Adverse effects can include leg cramps and hot flashes. Some more on raloxifene, or Evista. Your patient teaching: do not breastfeed or become pregnant while taking this drug. That is part of your teaching. You're questioning when they're starting on it. Do you have any plans? What are you using for protection? Absolutely cannot get pregnant. You'll see the calcium supplement seems to go along with all osteoporosis drug management. They'll say to take a calcium or a calcium and vitamin D. Weight-bearing exercises, which is also part of osteoporosis prevention and management. The weight-bearing or impact increases the bone density. No cigarette smoking. Cigarette smoking also aggravates, lessens your bone density. Also with using raloxifene and estrogen, increasing risk of clots. Avoiding prolonged inactivity due to deep vein thrombosis risks, such as sitting on an airplane for a long period of time. You need to advise them to get up, to move around. If they're sitting anywhere for long periods, to be moving their legs, pumping their feet, doing things. Teaching them signs and symptoms of an embolism and or a cerebral vascular accident, stroke. Changes in vision, blurred vision, pain on one side of the head, pain in the leg, red streak up the leg, shortness of breath, chest pain, foamy sputum. Could not think of that. Your next group for osteoporosis management are your biphosphonates. There's a list of biphosphonates also on page 804 of your Pearson text. And you can look in the front section of your drug handbook. There's a section on osteoporosis starting on 150C, where it has a list of, it talks about osteoporosis and management. It talks about your classes, your biphosphonates, and your SERMs, your calcitonin, parathyroid hormone, and it has a list of a couple of your biphosphonates there. All of them inhibit bone resorption and decrease the bone resorption, indirectly increasing your bone mass density. It's by stopping it from getting worse. Alendronate, ricindronate, ibandronate, Zoldronic acid. Zoldronic is the only one that's a little different as far as the dronate at the end of it. Fosamax, Actonel, Boniva reclassed. All of these can cause abdominal side effects of abdominal bone, joint, and muscle pain. All are contraindicated with if they have kidney issues and if they already have low calcium serum serum calcium levels. Contraindications, let's see, kidney problems, low calcium, pregnant or planning to become pregnant, and lactation. Contraindicated if they have a history of difficulty swallowing or heartburn. They are not to take an oral biphosphonate. The biphosphonates, I think I have it on the next. Yeah, I'm going to talk about that on the next page here. Okay, so a couple of the biphosphonates that we will focus on, the oral biphosphonates that we will focus on. Alendronate or Fosamax and risendronate or Actonel. Risendronate sounds a lot like risperidone, which is an antipsychotic, so do not get them confused. Look at that dronate on the end for a biphosphonate. These two, alendronate and risendronate, are oral biphosphonates. They're taken by an oral route. Both of these can be taken by men or women because the men do get osteoporosis for multiple reasons. Sometimes it's with age, and especially after like a prostate cancer, testicular cancer, certain things that mess with the testosterone in the body can be taken depending on the drug, their daily, weekly, or monthly dosing. The risendronate is good for corticosteroid-induced osteoporosis, people that have been on corticosteroids, even if they need to continue on them, and it's causing the bone loss. Risendronate is a good one that can be prescribed to protect from this loss for that person. Not alendronate, but risendronate. If somebody's going to be on corticosteroids for a long period of time, they may put them on the risendronate as a protective measure. Oral biphosphonates, big side effects. Pain in the chest and esophagus, difficulty swallowing, heartburn, abdominal pain, nausea, headache, rash. The big thing with the oral is that it can cause erosion in the esophagus, actually perforation. That's why pain in the chest or the esophagus, difficulty swallowing, are huge red flags that need to be reported immediately due to that risk of significant erosion. Your alendronate is in your drug handbook, page 43. Your risendronate is in your drug handbook, starting on page 1016. But I am giving you the information I think is most important for you to know. Some other biphosphonates that are for women only are the ones that come in other forms other than oral. Is ibandronate or Boniva, zoledronic acid, or reclassed. Your ibandronate can be oral or intravenous. If it's given oral, it's all the same risk factors as any other oral form. Your zoledronic is an IV drip only. So you can see here your ibandronate helps lower the risk of spinal fracture. Zoledronic or your reclassed increases bone mass to protect against fractures. Side effects of any intravenous biphosphonate is fever, muscle or joint pain, and headaches. If you notice, the muscle, joint pain, headaches is the same for all biphosphonates. Some significant specifics for zoledronic or reclassed is adverse effects, low blood pressure, dizziness, fatigue, the same headaches, muscle pain, nausea, constipation, fever, possible rash, weakness. They get the reclassed, I can't remember if it's once every 6 months. It's not very often, and their symptoms can last as long as 12 days after the infusion, but then will stop. Patient teaching for your biphosphonates. This is when they're taking the oral form of the biphosphonate. It is to be taken first thing in the morning on an empty stomach. Always to take with at least 8 ounces of water. Do not take with any other beverages. Remain upright, sitting or standing. No laying down for a minimum of 30 minutes after taking the medication. These are all very important because of the esophageal damage that can happen. Do not take any additional medication, beverage, or food for 45 to 60 minutes after taking this medication. They need a good dental exam prior to starting any biphosphonate, because all biphosphonates have a risk of developing a jaw or tooth problem called osteonecrosis of the jaw, which actually necrosis of the jawbone. They are to immediately report thigh pain. All biphosphonates, especially the Fosfonax, has, oh, I should give you the, generic name is your alendronate. That 5 to 10 years, I think it's 10 years is the max that they have to switch you to something else because of a femur fracture. That's why immediately reporting thigh pain because of risk with biphosphonates is an increased risk of stress fractures. Atypical femoral fractures is the most apparent, like the thigh in the hip. So that's why they're reporting the thigh pain. They're to repeat bone densities every 1 to 2 years, taking them off the biphosphonate as soon as possible. Taking calcium and vitamin D supplements too. Calcitonin is another treatment for osteoporosis. Calcitonin is a synthetic hormone that is naturally produced in your thyroid. You can read about it in your drug handbook on page 184. It slows the rate of bone resorption from the osteoclast. Only used in women with greater than 5 years postmenopausal. It's best. It works best for the woman with the greatest osteoporosis risk. It antagonizes the effects of the parathyroid hormone. It is given by injection. It's subcutaneous or intramuscular. The subcutaneous is something that the patient can learn to do themselves. The side effects is that it's injection only, sub-Q or IM, not oral. The side effects: nausea, vomiting, and flushing. Giving it and teaching the patient to take it at bedtime sometimes decreases the nausea and vomiting side effects, and that the nausea and vomiting should subside over time of being on this. It also can be given in a nasal spray. Need to teach them to do it properly. It can cause nasal irritation or bleeding, back pain, which is interesting, and headaches. There is salmon in calcitonin. That's the derivative it's coming from. So it is contraindicated if they have a known salmon allergy. They're to immediately report any rash, itching, or shortness of breath because of the potential for an allergic response. When they're taking the nasal, it goes in one nair. You to teach them to sit perfectly upright. Do the spray straight up and away from the septum. Never spray toward the septum. They're to go in as far into the nair as they can and do the one spray on one side, and to rotate sites when you do this once a day on either side. Your little drug handbook talks about parathyroid hormone. We're not going there. We're sticking to the calcitonin here. Okay. And then there's actually biologics that can be used for osteoporosis. We're going to focus on denosumab or Prolia. It's in your drug handbook starting on page 340. It can be administered to men or women. It works best with the high-risk postmenopausal woman or the woman that has had a history of a bone fracture or has multiple fracture risks. The osteoporosis, lack of or inability to do impact exercises. The smaller, tinier, fragile bone female is higher risk, and the further out most menopausal. And the less bone density they have, puts more risk. It's also used, this biologic can be used in treating the patient with a high fracture risk due to glucocorticoid treatment of long-term steroids, prednisone. There's a protein called the Renkel. You don't have to know the name of that protein. That this denosumab blocks the bone resorption caused by that protein. It is a sub-Q injection given every 6 months. Caution in renal dialysis patient and immunocompromised. It's not contraindicated, just with caution. Watching any of these osteoporosis drugs, you're watching their kidney function, risk of kidney stones or decreased kidney function. Always given with a calcium and vitamin D supplement. Contraindicated like the others if there's a low calcium level or pregnancy, not to get pregnant while they are on it. They're taking this denosumab. There's an increased risk of infections because it is a biologic. That's why it's caution in the immunocompromised patient, and they have a risk of that osteonecrosis of the jaw. Oh, I thought I left this out. I guess I did put it in. I apologize. The parathyroid hormone. I forgot I did put this back in. It's called an anabolic, this parathyroid hormone. This is the only parathyroid hormone. Teriparatide is the only parathyroid hormone that is FDA approved at this time for the management of osteoporosis. It's in your drug handbook on page 1125. It stimulates osteoblast function, increases gastrointestinal and renal tubular calcium absorption. So it works in a couple of ways to increase your bone density and strength, both by making the osteoblasts work harder and your body hang on to more of your calcium. That's why you need good renal function. So it increases your bone density and strength, which leads to a decrease in fracture risk. It can be used in men or women at risk for fractures. It's a sub-Q injection given daily with a pen. It can be used a maximum of 2 years because there is a very rare bone cancer that taking this anabolic parathyroid hormone teriparatide puts them at great risk for developing this rare bone cancer. That is it on your osteoporosis drugs. So 12E, module 12, exemplar E, is on your in your metabolism on your thyroid diseases. We're just going to touch on the thyroid drug management. I think we're a little ahead of you on the med surge. Okay, so anti-thyroid drugs, there's a few of them. The two we're going to touch on is methimazole and propylthiouracil. Oh goodness, I cannot say that. So you give anti-thyroid when the person is hyperthyroid, when the thyroid is grotesquely too active. In case you guys have not covered this in MedSearch 2, I always think of your thyroid as being like your motor. And I talk about revving the engine up and revving the engine down. So a hyperthyroid, the engine is very revved, eyes bulging, you have your heart rate racing, your skin is oily, bowels are very loose, they're losing weight, reflexes are hyper, everything is revved up. So they give the anti-thyroid to pretty much kill the thyroid, to get it to stop. Sometimes they can be successful in getting you out of a hyperthyroid state, but there's times they're doing it while they're buying time so they can do surgery to remove it, whether it's a tumor or something. And a lot of times after they do something to stop your thyroid, if it becomes inactive, your levels get too low and you end up on a thyroid hormone because you become hypothyroid. Anyway, so for the anti-thyroid, for the hyperthyroid, these are the two medications. It's not a long-term medication. You might not ever encounter these in your career. Methimazole I cannot find in your drug handbook, but your propylthiouracil is on page 976 in your drug handbook. You don't need to know too much about them. They're both category D in pregnancy. In other words, do not give them when they're pregnant. The treatment is usually about 2 weeks. It is managed by an endocrinologist. This is why you may not encounter it because it's short-term treatment, but having understanding if somebody has ever been treated for hyperthyroid. Anybody in a hyperthyroid state, you are always watching for an exacerbation or a thyroid storm because that can be life-threatening when everything is revved so high. Giving these medications to slow down that thyroid, the adverse effects are dizziness, headache, paresthesia, that's that numb tingling, usually in the fingers and the toes. It may be other places such as the lips. Nausea, vomiting, diarrhea, smoky urine, and that's what's listed, and that's the best way to put it. It's kind of cloudy. Renal impairment, nephritis, which is inflammation in the kidneys, rash, muscle pain, enlarged thyroid. And note there, I put stars on it, liver and bone marrow toxicity. That's especially with your propylthiouracil. This anti-thyroid agent works by blocking your thyroid from from producing your thyroid hormone. There is a black box warning for severe hepatic injury, acute hepatic failure, and death. So if you're thinking of these bone marrow and liver, you're looking at your LAMS, your AST and ALT, but you're also looking at alkaline phosphatase, which has to do with your bone and your liver, your bilirubin, which is your liver, and your prothrombin time, which is part of your clotting time because of your bone marrow toxicity potential. So the opposite, hypothyroid, when the engine is too low and you need to replace the thyroid hormones, there's a couple of drugs that can be given. Levothyroxine, you've heard of Synthroid, is a very common brand name for levothyroxine, which is T4. Liotrix is T3 and T4. Armour Thyroid is an over-the-counter, but that sometimes actually is prescribed. Out of the three, levothyroxine is the most stable, direct. They know exactly how much thyroid hormone you're getting, where the other two are not always quite exact. Um, Again, I don't know if you've covered in med-surg yet. So your thyroid hormones, your T3, T4, you have your TSH. Just going to say it briefly here. TSH is thyroid stimulating hormone. It is released by your parathyroid when your thyroid level, hormone level is too low. Your parathyroid releases TSH to try to stimulate your thyroid to secrete more thyroid hormone. So it's the thyroid stimulating hormone. It is elevated when your thyroid hormone level is too low, and it is low when your thyroid hormone level is too high. The TSH, or thyroid stimulating hormone, is lower to try to stop your thyroid from producing more thyroid hormone when it has too much. Okay, so back to your thyroid hormone replacement. The adverse effects are related to how much dosing, what their thyroid level is. So they're hypothyroid, and if they're getting too much thyroid hormone and their thyroid levels, T3, T4, are getting too high, then they're going to have symptoms toward the hyperthyroid side. Tachycardia, palpitations, insomnia, headache, loose bowels, diarrhea, nausea, vomiting, cramping, things that the engine is revved up too much. It's very important to teach someone if they're starting on like a hypothyroid patient that is on thyroid hormones. You're going to teach them the symptoms of both hypo and hyperthyroid to report. Because even though they're hypothyroid, they're going on replacement. If their levels get too high, they're going to have thyroid, hyperthyroid symptoms, and that can be dangerous and life-threatening, put them in arrhythmias or irregular heart rhythms that can be life-threatening. Contraindications for taking was recent MI, not because that they've had a heart attack ever in their life, but just recent adrenal insufficiency, and obviously if they're hyperthyroid, you don't want to give them more thyroid hormone. There's a few drug interactions. I divided them into ones where the thyroid hormone will reduce the effectiveness of your phenytoin, antacids, and estrogen. Will decrease the absorption of those three. And taking levothyroxine or thyroid replacement increases the effect of your warfarin, which you could think of as a blood thinner, so increased chance of bleeding. So you'd have to keep a closer eye on your warfarin, your PT, for managing your warfarin. And I think, yep, that is the end of your drugs for Module 12.